Hi, it's Dr. Noel Williams, Optimal Health Associates, Oklahoma City, Oklahoma. December 2nd, 2020, COVID update. So today wasn't a great day for Oklahoma. 2,800 new cases, 54 deaths, which was a tragically high number. We're 202,000 total cases. Numbers until today had gone down slightly per day. That may have been because of the holiday diminished testing. There could be a chance that maybe we're getting some improvement in case development. We'll just have to see over the next 5 days. Be optimistic. If we're looking at statistics, since 3 weeks ago, we're about 8% higher mask wearing, which means about 20% of the 40%, which equals 8%, of the people who weren't wearing masks have started wearing masks, and that's exciting. From between the state mandating all state workers wear masks and some of the communication, so that's a positive. I would really like everyone to strongly consider wearing masks. The trend of the data continues. I just read another paper that they are helpful for at least the wearer in this case. This paper, which was a Danish paper, which was derided as fake news on Facebook because it didn't show that it didn't look at a societal effect, it looked at an individual effect, and so its conclusion was the trend was it was protective to the wearer. And so that was fake news because they didn't say it was societally beneficial, but they weren't looking at societal benefit, they were looking at individual benefit. So God forbid anyone follows science anymore and just is honest. Likewise, the other high point, I think, in media news was Fauci was named People Person of the Year, which makes me never get a People magazine again. But at least on the positive side, Fauci has been a little more open-minded on a few things. And you know, what can I say? The debacle we're in now really has to do with him and a few other political figures and everything. But you know, be that as it may. So what do we need to do? The things we need to do. I had 2 hours of meetings last night with the governor's office leadership team with a bunch of doctors. We had another hour meeting today. The doctors involved had many hours of meetings around that. So the Oklahoma update specifically is there's actually an ongoing plan from the Oklahoma State Department of Health and Lance Fry, who's the only person I'll name because he's a public figure, but there's many other people, deputy secretaries and stuff, who are working on all different aspects of the potential surge plan. And I think that's something that unfortunately has not been in the media, not gotten out, that there really is a stepwise progression at the state level within the Oklahoma Department of Health to integrate hospital services, LTAC, step-down units for patient transfer, behavioral hospitals. There's a whole bunch of things being done behind the scenes, and they're behind the scenes because it's boring, it's logistics, and people don't. It's not that interesting to hear about patient flow and throughput and how do we, if we have a patient in Guthrie, call the AMSA because they're sick with X, how does that person get, where do they go, and what's the flow? And then once they get to the hospital, what happens to them within the hospital? And then if they have COVID or they don't have COVID and they get services, then how do we get them out of the hospital to a step-down unit or back home? And making that entire system, believe it or not, run smoothly and efficiently when you're looking at like a potentially mass casualty type event that's ongoing takes time and effort, and the state is really paying attention to it. So I want people to have confidence in the efforts of the state to do this stuff, because I think they really are focused, and the leadership team is really, really focused that I'm working with on getting this done. And no matter how you feel about some of the statements that come out in terms of, and again, I'm just going to address it head on, from the day the governor's comment about prayer and fasting to, you know, the state's potentially in the Lord's hands. The reality is that there are lots of state people who are paid by us that are working very, very hard to organize things. And while sometimes the perception in the media is one way, there are people really working hard to do this. I mean, the CEOs of the Central Oklahoma hospitals, again, I won't name them, but Norman, St. Anthony's, OU, Integris, and Mercy are working night and day with their teams, with state leaders of different divisions. And this group of CEOs is really doing everything they can. And I'm assuming it's the same in Tulsa. I don't know, though, but I can tell you in the Oklahoma City area, the acute care hospital CEOs, then the specialty hospital CEOs, again, are meeting, coordinating, establishing routes of transfer so we can have the maximal response ready over the next 3 to 4 weeks if it goes the way we're worried about. But we'll have to see. But I think that's really important, that there's reasons for optimism about our care in Oklahoma, especially central Oklahoma, and there are people who care. And I think that matters. And even though these numbers were bad, there's things we can do to help ourselves. 1, wear your mask. 2, stay home. 3, wash your hands. Socially distance. Don't go out if you don't need to. If you go to a big box store, bring your alcohol wipes with you. Not so much because it's grabbing the materials you need, it's going in and out. So the second you walk in, use that hand sanitizer, wear your mask, and be smart. Now, in terms of supplements, again, we have so many people who've gotten COVID now in the practice, and for the vast majority, they've done incredibly well. What we're seeing, though, is we did have someone get admitted because of they sailed through their COVID, but then they got a secondary bacterial infection suddenly and got sick, but they did great with their COVID. And that's the thing you have to realize about COVID. You can get secondary bacterial infections, you can get all kinds of pulmonary complications, and this blood clotting thing is really, really becoming more and more obvious. So one of the things everyone should really be on is a fish oil capsule, unless you're allergic to fish oil. I mean, everybody who's an adult should be on one. Again, FDA suggestions. I would always say 750 milligrams of EPA to DHA in at least a 3-to-1 ratio or more. If you're a high-risk person for clotting, you need to talk to your doctor or provider, because if you get COVID, you're at very, very high risk for clotting. So who's at high risk for blood clotting? Well, people who are on oral contraceptives, people on oral estrogen, people with established clotting abnormalities. Now, if you have an established clotting abnormality, as I've mentioned before, if it's a genetic one, you have children, you could have passed it to them, so make sure they're aware. And so, again, fish oil, fish oil, fish oil. Some people may need aspirin or Xarelto or Eliquis or something. Those are more aggressive interventions, and you need to discuss those with your provider. Likewise, we're seeing some data coming out of England showing long-term lung damage in patients who just had COVID symptoms that were mild to moderate to severe within the outpatient realm, and with some long-term lung damage. So again, you want to call your doctor if you get COVID, and if you're getting lung symptoms, asking about steroids is a good idea. I would strongly encourage that. So that's the update for today in terms of the core stuff. We're continuing to work with the state very, very closely on, steps to help. I mean, that's all we can do. There's a lot of people involved. It's taking a lot of I don't know what the right word, a lot of hours anymore. I used to say man hours. I don't want to say that anymore. Women hours, because, one of our lead people is Julie Watson, who's amazing, the CMO at Integris. So anyway, again, there's lots and lots of people putting, untold hours in on top of their day jobs. And so if I look tired, yes, I'm tired. But whatever. So it's a lot of work, and trying to do things for a large population isn't always as easy as we'd like it to be. And also shout out to the people at OU and the public health school who've provided statistics to us, to our group, and everybody else who's helping everybody. So thank you. And Kim has some questions for me.
Mm-hmm. Okay, the vaccine that's coming.
Okay, so the vaccine, it's going to be some kind of RNA-derived vaccine. It looks like our first doses will get here December 11th is the latest update. It's going to be the Pfizer product is what my understanding is from the state health department. The Pfizer product looks like a reasonably safe. Again, the efficacy is based on the idea your antibody levels coming up to the same level as someone who got sick with it. Again, we don't want to get into the whole question of this, the person who already had it, had those antibody levels that high, did they need a vaccine? But we'll leave that alone. But the bottom line is, COVID's a deadly disease. If you're in the pot of people who are at high risk for getting it, so you're older, you have a whole bunch of comorbidities, you're a first-line hospital worker for COVID patients, I would encourage you to get it. I mean, at this point, you don't want to get COVID. I don't want you to get COVID. And if this helps, I think it's worth the risk. But again, in a perfect world, we would have a study showing its actual effectiveness in terms of clinical outcomes, and we would have an idea of the risks. So far, in the people who have gotten it, there hasn't been any huge problems with the Pfizer vaccine. Now, if it was the AstraZeneca vaccine we were getting, I would have, that one's had some, the data isn't as good. There's been some snafus in the studies that go directly against the promise Big Pharma made about the vaccine, and suddenly AstraZeneca doesn't give a hoot about that. And also the side effect profile looked much different. The thing to keep in mind about the vaccine, though, the vaccine is going to have side effects. You are going to usually get sick from the vaccine. Like you're going to get a mild case of COVID for 24 hours. It's not really COVID, but it's the immune response to COVID. So again, if you're a high-risk person, I definitely would consider taking it. If you're not a high-risk person, you're not going to get it for 3 to 6 months anyway. And so then you'll just see what happened to everybody else. And if it's turned into a disaster, well, you know not to get it. But I mean, that's where we are with the vaccine. You have to look at it from it is what it is. We don't have the data to know if it's safe or not. But if you're at a high-risk group, it's hard. It's hard to say not to do it because, you know, it could kill, the virus could kill you or give you long-term disability. And the long-term disability thing is going to be massive. I'm 56. I mean, the rest of my career is going to be dealing with post-COVID events. I mean, the next 15 years, if I actually work that long, which I probably won't. But,
Thank you.
but you know, however long I work, I'm going to be dealing with COVID ramifications on all the damage it does to people who've gotten it, even the people who just didn't get hospitalized. So that's how it goes. So anyway, next question.
Well, so on the COVID vaccine, if the virus is mutating, is that going to be like the flu vaccine where they have to kind of chase it every year, or is it the same concept?
Well, I think ultimately we know that cold viruses mutate. Coronaviruses mutate, obviously, because we went from corona to SARS-1 to MERS to the one I'm forgetting, and then it went to SARS-2. So SARS-2 or COVID is going to mutate. And so the question is it going to mutate away from the vaccine? And the answer is yes, at some point it's going to mutate away from the vaccine. Will you have cross protection? Maybe, because 30% of people with coronavirus have protection against COVID. I can't order the test to see who you are, but it's well established in studies. So the answer is the COVID vaccine, if it is protective to COVID, which I don't know if it is. No one knows if it is, but it theoretically could be. If it does protect you against COVID, COVID is most likely going to mutate away from that protection eventually. I don't know when, nor does anyone. It could be 6 months, it could be 6 years, it could be 6 weeks, but it's probably not going to be 6 weeks.
Okay, so one more vaccine. If a patient received a convalescent plasma, would that person still need to get the vaccine?
Well, if you receive convalescent plasma, it means you got COVID. And so if you've gotten COVID, you made the antibodies. So the party line is you have 3 months of protection. I think it's probably longer. It could be much longer. Now, if I had a choice of getting asymptomatic COVID and getting an antibody response or getting a vaccine, and depending on one of the two of them for immunity, it would be getting COVID. That's the classic data. Anyone who says that isn't the best way to protect yourself is wrong. I want to say idiot or an ass. I mean, they're just wrong. But, that's going to get this video pulled. So, there we go. So when this one disappears, you'll know why. Getting the illness is what's most protective. Vaccines are not as effective as getting an illness because your immune response is the full natural response to the illness. And you get exposed to all the antigens, so you have the opportunity to make a variety of antibodies that are neutralizing. So anyway, that's always going to work better. So, but again, the narrative is everyone gets the vaccine.
Okay. So if you get sick, how do you know where to go? Whether it's COVID or anything else, how do you know which ER to go to at that particular time? Do you just call?
No, if you get sick with COVID, first call your primary care provider's office, assuming that you're not that sick, and try to see what directions they'll give you. So the reasons to go to the ER, and you got to keep in mind, when you go to the ER, they're packed. For example, on the East Coast, some of them are running 8 to 12 hours of wait time. We're not at that point here, but we could get there. If you go to the ER, you only want to go if you're having more significant shortness of breath, your heart rate's over 100, and it doesn't have to be all of these, it's just some combination therein. So your shortness of breath is increasing, you're having difficulty breathing, any kind of chest discomfort, chest pain, tachycardia, heart rate over 100 when you're laying still, high fever, over 103, then you're going to want to really consider going in. And then the global thing, how do you feel? I mean, if you have a fever of 103 and your breathing's fine and your heart rate's going to be up because you have a fever and you just feel crappy because you have the flu, you don't need to go to the ER. It's if you feel sick, like I am worried I'm going to die or I can't catch my breath, that's when you go. And this brings up another subject. The ERs are being inundated with people with, oh, my back hurts. And they get the question, how long has your back hurt? 6 months. Well, what made it bring you in tonight? Oh, I just couldn't take it anymore. You've lost your brain, okay? I mean, I don't want to say you're an idiot, but you're an idiot. Don't go to the ER for stuff like that right now. I know you miss going to the ER because of the attention it gives you, all right? I feel bad for you that you're not getting the attention you need. This isn't the time to go because it could cause you to die. Likewise, if you're feeling emotional, where is the last place you need to go if you're feeling anxious or depressed right now? It's the ER. They're not good at it anyway. They don't like it. It's reality. So don't go now. Call your primary care provider. If you don't have one, go to an urgent care during the day and go in and say, I'm anxious and depressed. They can deal with it. ERs are not for that stuff.
And most people probably know the difference, but just in case, what's the difference in an urgent care and an ER?
An ER is at a hospital. An urgent care is like Access Medical Care. For example, very nice folks there. There's a variety of urgent cares around. Most of the people who work there are nice. Okay, not that the ER people aren't nice, but the ER people are getting crushed with COVID. They're stressed to the max. So going there is not smart. You're going to get sick and you're not going to get good care because they're going to be like, why the hell are you here? Go home. Get out of here. They are not set up for that. And I'm not belittling feeling sad or anything. If you're in our practice, we'll see you in a second. If you're not, you got to call your primary care. That's what we're here for, is to take care of that stuff. We can handle sadness and anxiety, but they can't. So don't go there. And that's what I'm hearing from these chief medical officers, that we're getting inundated with the chronic back pain still and all this other stuff when we're jammed, and we need people to be smart. And it's not that we don't care about you. It's just, let's think about the right places to go to right now. Now, if you have a broken limb, you think your tummy's hurting a lot, you have severe, horrible, sudden neck pain, yes, you still go to the ER. But if you have regular, chronic, annoying things, don't go to the ER.
So back on the original question. So say you absolutely need to go to the ER. How do you know where to go?
It's random luck. I mean, they're all jam busy. They're all very, I mean, if you look at any of the Integris facilities, any of the St. Anthony's facilities, any of the Midwest City facilities, any of the OU facilities, who am I missing? Any of the Norman facilities. So all of our central Oklahoma hospital systems are fantastic. There's nothing but excellence for the most part there. It's just they're overwhelmed, so only go if you need to go. You're going to get the best care that's available currently. It's not going to be usually as good as it was because they're overwhelmed. There's a massive nursing shortage, and let's give a shout out to the nurses. The nurses are getting crushed with this. I mean, the doctors may be getting biffed a little. The nurses are getting crushed with the work. If you know a nurse, be nice to a nurse. Be nice to them. Buy them lunch, buy them dinner, give them flowers. They are working harder than any group has worked in forever in this country. And so just keep that in mind. So again, going to the hospitals is a disaster now. There's no upside. You go if you absolutely have to go. That's the only reason to go.
How do you feel about ivermectin as a preventative?
Ivermectin, which is dog dewormer, there's some basic science articles on its use for prevention or treatment of COVID. I think they're self-explanatory. I've posted about it, and that's all I'm willing to say about it.
Okay. One more. If you've had COVID and you've recovered, what is the purpose of wearing a mask and social distancing?
The reason you're going to wear a mask and social distance is because most people around you are not going to know that you actually had it. And so you want to be part of the solution, which is wearing a mask in public to help the flow of the containment. I mean, I understand that you're not going to probably get it again almost any time within the next 3, 6, or 12 months, but until something changes with the data. But people around you aren't going to understand that who don't know you. So you just do the simple thing to make life easier on everyone. If it's important to you to draw a line in the sand and let everyone know you got it and you're fine, hey, more power to you for causing conflict. Way to go. But I think during this time, it's just a lot easier to wear your mask and don't tie it tightly. Okay? I mean, just fake it for the group. I think that's the reason to do it. All right. Good night. I'm going to bed.